Welcome back to the ProPA podcast. I'm your host, Prof. G, and you're listening to another high-yield clinical medicine brief in the MSK101 series, where we tackle musculoskeletal and rheumatologic disorders straight from the PANCE blueprint. In this episode, we'll be discussing Sjögren Syndrome, an autoimmune condition that's easy to overlook, but important to recognize in both clinical practice and on the boards. In this episode, we'll cover high-yield facts about the disease to help you ace your PANCE or PANRE exam. Let's dive in. Did you know that Sjögren syndrome is named after Swedish ophthalmologist Henrik Sjogren, who first described the condition in 1933? It's one of the most common autoimmune disorders affecting exocrine glands, particularly the salivary and lacrimal glands. So first, let's look at the kinder patho. What is Sjögren syndrome? Well, Sjögren syndrome is an autoimmune disease which is chronic that primarily targets the exocrine glands, like we mentioned before, especially the salivary and lacrimal glands, leading to decreased production of tears and saliva. This can be primary, which occurs alone, or secondary, which is associated with other autoimmune diseases like rheumatoid arthritis or SLE. The immune system attacks the glands, leading to lymphocytic infiltration and glandular dysfunction. So, how do these patients present clinically? Well, the classic symptoms include dry eyes or xerophthalmia, which creates kind of a gritty or a sandy sensation, especially with blinking. It can also cause dry mouth or xerostomia, which is difficulty swallowing. It leads to dental caries and oral candidiasis. We also see parotid gland enlargement, which is common in kids and in young women. We can also see fatigue and arthralgias, as well as vaginal dryness in some patients. Some of the more systemic manifestations may include arthritis, which is the non-erosive type, Raynaud's phenomenon, interstitial nephritis, and increased risk of a non-Hodgkin's lymphoma. Now let's look at the workup and the diagnosis. So, just like all the other autoimmune disorders, we got to look at the antibodies. So, we have positive autoantibodies, including the anti-Rho antibody, which is also called SSA, or the anti-La antibody, which are the SSB antibodies. And these are the hallmark findings on labs. An ANA can also be positive in most cases, however nonspecific. Rheumatoid factor is often positive without rheumatoid arthritis. Some other tests we can get include the Schirmer test, which measures tear production, a salivary gland biopsy, which confirms lymphocytic infiltration, or a sialometry or salivary gland scintigraphy, which measures salivary output. All right, now let's break down the treatment. So, we basically have to treat the symptoms. So, we see symptom based therapy, okay, including artificial tears and eye lubricants for dry eyes, sugar free gum or lozenges, pilocarpine or cevimeline to help stimulate saliva. We also encourage hydration and meticulous oral hygiene to help prevent those things like dental caries or oral candidiasis. We can also consider giving immunosuppressants like hydroxychloroquine or methotrexate for systemic disease. We have to monitor for complications like oral infections, corneal ulcers, or even lymphoma. Now let's look at the book med versus the street med. So book med, pretty classic presentation, dry eyes, dry mouth, positive SSA or SSB antibodies, and this is classic of a textbook case of Sjogren's. Street med, however, these patients may come in with kind of vague symptoms, just like some of the other autoimmune disorders, right? They might have some fatigue or some tooth decay or a dry cough. And diagnosis may be delayed if it's not on your radar, especially in postmenopausal women. So always consider Sjogren in unexplained Sicca symptoms. All right, let's wrap it up with some clinical pearls. Anti-Rho or SSA or anti-La SSB are the key antibodies. Most common that we see this in middle-aged women. There's a strong association with rheumatoid arthritis, SLE, and scleroderma. There's also an increased risk of non-Hodgkin's lymphoma. Don't forget the Schirmer test and the salivary gland biopsy that can help you confirm your diagnosis. Treatment is mostly symptom management. All right, now that we've made it through all of that instructional material, let's look at some practice PANCE questions to test our knowledge. Question 1. A 52-year-old woman presents with dry eyes, dry mouth, and recent dental caries. She is found to be positive for the anti-Rho and anti-La antibodies. What additional condition is she at increased risk for? Is it A, rheumatoid arthritis, B, non-Hodgkin's lymphoma, C, systemic sclerosis, or D, myasthenia gravis? I'll give you a few seconds. If you said B, you're right. It's non-Hodgkin's lymphoma. So patients with Sjogren's are at increased risk due to the chronic lymphocytic infiltration. Question 2. Which of the following medications is used to stimulate salivary flow in patients with Sjögren syndrome? Is it A, methotrexate, B, hydroxychloroquine, C, cevimeline, or D, prednisone? I'll give you a few seconds. If you said C, you're right. It's cevimeline. Cevimeline and pilocarpine are muscarinic agonists that stimulate salivary secretion. All right, so some final thoughts. Sjögren syndrome is a condition with subtle symptoms but big implications. Recognizing the classic symptoms of dry eyes, dry mouth, and positive SSA and SSB antibodies can lead to early intervention and improved quality of life for your patients. Thanks for joining me on this episode of the Pro PA Podcast MSK101 series. Stay tuned as we continue down the rheumatology path with our next topic in the series. And remember, this is the Pro PA Podcast, where future pros in medicine are made. Thanks for listening.